Lovely. Well, hello, good afternoon, everybody. My name's Pratima. I'm one of the paediatric gastroenterology consultants at the Royal London Hospital, and I'm going to give you a bit of an overview about the sort of referrals which are going to be appropriate for a tertiary paediatric gastroenterologist, and more importantly, which ones I think can be managed in primary care and secondary care, because often we get asked this question a lot, and just a bit of a pathway of when to refer, really. This is what this talk is about. I'd have loved to have made it interactive, but we'll just see how we go, because the way I've divided my talk, and I hope you can all see my slides, is I'm going to talk to you about common symptoms. So we all know that GI symptoms are common in children, but the ones I'm going to touch upon is loose stools. Okay, so I'm going to talk about diarrhea. I'm also then going to talk about reflux and regurgitation, constipation and abdominal pain. So a lot of my talk is going to be based on these four really common GI symptoms. Then I'll also touch upon rectal bleeding and when we want to see these referrals urgently and when they're less urgent. And I'm going to try and tie this in with a few cases to give you a bit of an overview of the sorts of cases that are good to come to us. Okay, so let's start with diarrhea. So really common GI complaint. You know, worldwide, we're seeing billions of cases annually. It's probably one of the leading cases of mortality in children globally. Significant morbidity. If we think about how many A&E visits, even in the Western world, we're seeing of children coming in with loose stools. So, you know, 6 to 12 episodes when they're under the age of 5 years. Accounts for 10% of hospitalizations, really importantly, 10% of preventable deaths. And depending on the kind of reviews you read, you know, up to 16% of medical A&E presentations are due to diarrhea alone. So it's an important one as pediatricians to really try and tease apart of when to worry and when not. And obviously in the acute setting, what we worry about is dehydration. So, you know, various sort of markers of dehydration. You can use clinical dehydration scores, Gorlick scores, urine analysis, ultrasound, but actually all of these measures are not very good clinically. I don't use them. I've used clinical dehydration scores in research, but certainly not on a clinical level. So what do we do? Very good, nice guidelines out there about how to assess dehydration. What are the high-risk groups? Well, they're really young. If they've got pre-existing problems like a low birth weight, actually, if their diarrhea is voluminous, so this comes from the history, is how many stools are they having in the past 24 hours? If it's more than 6 times, that's kind of significant. If they're vomiting more than 3 times in a 24-hour period, that's significant. Now, that's a bit different to the child who comes to A&E and they've vomited 3 times back to back. It's the ones where they've had 3 separate episodes of vomiting. That's a bit more significant to result in dehydration. The children who are not managing to take any fluids and keep them down, babies who are not managing to breastfeed, and of course, any pre-existing illnesses, and significantly, if they've got a background of malnutrition. So these are the sort of subgroups that you're worried about. And like I say, really good NASPGHAN, nice guidelines about the red flag symptoms. So actually, is the acute onset of diarrhea sepsis? You know, is the child febrile, respiratory distress, altered consciousness of rash? Is the diarrhea like dysentery? So is there blood, is there mucus? And actually, is this an acute abdomen? Is there any localized tenderness, any guarding peritonism? So, you know, all of that we all know about. Now, in terms of how we investigate diarrhea, well, it really depends on the child and their presentation. So if they're in the acute setting in A&E, I wouldn't necessarily do a stool culture. But if I'm suspecting sepsis, I absolutely will send stool for cultures. If there's blood in the stool, I will absolutely send for Salmonella, Shigella, Campylobacter, E. coli. If they're a background immune suppressed patient, I will send for parasites, for C. diff, for viruses, as well as culture. If there's a history of foreign travel, and particularly, and really significantly, if the diarrhea is going on for more than 7 days. And that's because, you know, you're thinking about public health and notifying any kind of contact tracing for notifiable diseases. But what do we do about this subgroup? This subgroup of patients where the diarrhea continues. So broadly speaking, this is what we term chronic diarrhea. And what does it actually mean? Depends on where you're at and which healthcare system you're in. But chronic diarrhea usually is diarrhea persisting more than 14 days. A more correct and accurate definition, I would say, is persisting up to 4 weeks. But it doesn't matter. More than 14 days kind of takes you away from the acute infective episode. Definitions wise, is it more than 10 milligrams per kilo in an infant or more than 200 grams per day in an older child? But as you know, that's really difficult to tease out on a history. So broadly speaking, it's loose watery diarrhea more than 3 times a day. Now, obviously, diarrhea doesn't have to be watery. It can also be malabsorptive, it can also be inflammatory. But generally speaking, we talk about chronic diarrhea being watery. And then we want to tease apart the history. So actually, how many times a day is the child having diarrhea? What's the frequency? What's the pattern? What's the relationship with eating? How is it impacting their growth and their nutritional status? And then from the history, you can establish whether the diarrhea could be secretory or osmotic. So with watery diarrhea, generically, if you suspect the child is going to be dehydrated because of ongoing diarrhea that's gone on more than 14 days, the first thing to say is you can't discharge the child because you've got to find out what the etiology of this diarrhea is. So, you may admit them overnight and put them fasting on IV fluids. Generally, with a secretory diarrhea, that won't make a blind bit of difference, and the child will continue to have watery diarrhea. You would do fecal reducing substances. Now, with an osmotic diarrhea, your fecal reducing substances will be positive, your osmolar gap will be really high. With a secretory diarrhea, that's the opposite. Your osmolar gap won't be high, your reducing substances won't be positive. So, there are ways of teasing out the kind of causes this could be. And really, depending on that, you then go into trying to find out what the cause is. So is it secretory? Is it osmotic? Is it malabsorptive? Is it inflammatory? Or actually, is it functional? So your baseline investigations are really looking under those headings. Could this be celiac? So absolutely send a celiac serology. Definitely send your stool for cultures, viruses, parasites. Could this be giardiasis? Send it for stool fat. So is there fat malabsorption? Reducing substances, as we've talked about, and really be guided by the history. So for example, if it's a child with background immune suppression, could this be graft versus host disease diarrhea? Would you be worried about any sort of tumours and do tumour markers? All depends on the history. But here's the really important thing. Chronic diarrhea, never normal. Even if it's functional, you've got to exclude all of these causes. So actually, these are the children I would have a low threshold about referring to us. The ones to refer, obviously, if they've got positive TTG, you have to refer them to a paediatric gastroenterologist. If they've got another form of malabsorption, if their albumin's low, if they've got low iron stores, low vitamin B12 or folate, and you're worried about this small bowel malabsorption, refer them to us because we may need to consider an upper GI endoscopy. Refer any child with diarrhea if the child is starting to, if the symptom is now impacting their growth and nutrition. That warrants a referral to us. Or actually, if you've excluded all the causes of chronic diarrhea and you just can't put your finger on what this is, refer those child to us. So really, the bottom line is with these children, have a low threshold about referring on to us, but in your secondary care, do the baseline investigations to try and really narrow down the spectrum of disease. So let's talk about this case. This is a real case, happened 2 weeks ago at the Royal London. So I was on call and I got a call from a local DGH about a baby born preterm at 35 plus 4 weeks, good birth weight, 2.56 kilos, meconium at birth, so got admitted to NICU just for empirical antibiotics at birth, and was self-ventilating there. Obs were completely fine, but then on day 2 of life started express breast milk and really crumbled. So crumbled, needed resuscitation, had a really significant metabolic acidosis, and just profound watery diarrhea. So much so the baby was needing fluid boluses, IV bicarb corrections, and obviously then the IV antibiotics were continued for queries of sepsis-related metabolic acidosis. The baby within a week lost 22% of her birth weight. Despite being kept nil by mouth, the watery diarrhea was profound and profuse and continued, but interestingly, the BMs for the baby were normal. So on day 9 of life, the feeds were restarted, so it was expressed breast milk, but actually the diarrhea continued. So at that point, we thought about cow's milk protein intolerance, and so we changed the feeds to Neocate. Actually, that didn't make any change in the watery diarrhea. The baby's septic markers were all normal, CRP normal, blood cultures normal, stool cultures normal, parents were non-consanguineous, The metabolic markers, ammonia, galactosemia, all of that normal. And by day 10, despite being on Neocate and being on more than 200 mils per kilo per day of fluid, so, baby was started on PN and was needing these massive volumes just to keep the pH normal, and was just, not getting anywhere with enteral feeding. So at that point, the District General Hospital, very early on, so only day 10 of life, picked up the phone and called me. And I transferred the baby over to us almost immediately, so almost overnight transferred to us, because this, by definition, was a congenital diarrhea. So, this was not metabolic. This was very much related to feeding. There was a profuse secretory diarrhea in the face of fasting, and the baby was developing acidosis every time the baby fed. This had to be GI unless proven otherwise. I wasn't worried about metabolic. So I brought the baby over. The baby actually stayed on PN for 4 months. So TPN continued on this baby. Really slow weight gain. And actually 2 weeks ago, just because we were not winning with the baby, usually we wouldn't scope a baby below maybe 5 kilos of weight, but the baby literally at 4 months of age was only 3 kilos, which is just about manageable for an endoscopy. And so we then 2 weeks ago took the baby for upper GI endoscopy. The small bowel macroscopically just looked a bit like atrophy, so the mucosa looked like it was atrophic. But actually on electron microscopy, if you can see these pictures, these are inclusion bodies. So this clinched the diagnosis here of a condition called Microvillous inclusion disease. Really, really rare. It's a congenital sort of autosomal recessive diarrhea. This baby will end up needing potentially lifelong PN and probably later down the line an intestinal transplant. So, the take-home message here was this DGH didn't sit on the baby, didn't continue doing septic screens, didn't continue to do metabolic workups, but actually referred early, and that was spot on. It was the right thing to do, was refer to us. So now I touched upon clinching that diagnosis with an upper GI endoscopy, and obviously that's one of the reasons why anyone would refer to a tertiary gastro department is for endoscopy. So what are the indications for endoscopy? And these are sort of generic indications. I think they're not exhaustive because, it's a patient by patient decision of who we scope. But certainly any child, regardless of their age, who's failing to thrive, where growth is a concern, they will have a low threshold for doing upper GI endoscopy, because what we're looking for is small bowel mucosa. Is there a malabsorption going on that we need to actually address? Unexplained anemia, for example, we would do an endoscopy to look at is there GI ulceration. Now, if the child is having abdominal pain, and I'll touch on abdominal pain later on in the talk, but let me talk about this, is abdominal pain, but where there is an index of suspicion of organic disease, we would scope them. If there's any swallowing difficulties, obviously any kind of alkaline or acid ingestions, recurrent vomiting where you've not proven a cause for the vomiting, hematemesis, obviously any, like we said, unexplained chronic diarrhea, if they've got immune suppression or suspected graft versus host, Barrett's esophagus, or chronic gastroesophageal reflux disease where we are surveilling for Barrett's disease. Now on the right-hand side, you will see there are therapeutic indications. Now these are depending on the kind of GI unit as your tertiary unit, depends on their expertise. So we do these, so we can do PEGs, we can do duodenal placements, we can remove foreign bodies, we can inject for varices. So all of those things we can certainly do achalasia and dilatations with our pediatric surgical colleagues. And obviously upper GI polyps, we can remove them. So these are therapeutic indications. Now the really important thing here is these two that I've put down there. No indications for an upper GI endoscopy is uncomplicated gastroesophageal reflux disease. We would not scope these children. We don't need them referred to us. And obviously functional GI disorders, we do not scope these children. We do not need them referred to us. And I'll talk about it as I carry on in my talk. So this comes up with my next bit on gastroesophageal reflux. You can imagine, I would say probably 40 to 50% of my general GI clinic is full of these. And actually, I don't think they need me. I don't do anything for them, and they can be managed by a GP, let alone a general paediatrician. But reflux, definition of it is effortless passage of gastric contents into the esophagus. Regurgitation is when those gastric contents come into the mouth. If they're ruminating, they often chew the food in their mouth and then swallow it back down in the older kids. And actually, you can see that reflux is so common. It's a physiological process, really common under the age of 1. Contrast that with gastroesophageal reflux disease. Now, this is where the child is having the impact of the vomiting on their growth. They may be having acute life-threatening events like going blue and cyanotic spells, apneas. They may be gagging on their foods, choking, having respiratory symptoms. Water brash is where they produce a lot of saliva that's mixed in with their gastric contents and they're bringing up in their mouth, and it's just a horrible symptom in the older children. They may be getting swallowing difficulties, pain on eating, central chest pain, crushing, burning, epigastric pain. But you will see the symptoms of GORD are far less common. So, the percentage becomes a lot less. Now, how do we diagnose reflux? Now, here's the thing. You can't really, it's very clinical. So reflux is a clinical diagnosis, but you want to exclude the other causes. So take a really good history. What is the relationship of vomiting to actually eating? What's the growth of the child like? What is the child feeding? What is their milk? How much volume are they taking? How often do they feed? Do they get any abdominal pain or any constipation, any bloating? Are there any psychological factors impacting this for the older children? And really, there's a stepwise approach depending on all of those symptoms that you've gleaned from your history. The first is if the child is vomiting but the growth is okay, we'll just reassure them. Talk about diet and lifestyle. So one of the things is in parents with the baby who's vomiting, if either parent is a smoker, you can talk to parents about the association of tobacco smoking with reflux in children. Talk about positioning, maybe give them a trial of Gaviscon. Now, when I say give them a trial of it, I would say 2 weeks is enough. If it's not helping, then, stop the Gaviscon. Do I use prokinetics? No, not under the age of 6 months. Do I use PPIs? No, not under the age of 6 months. So, there's no evidence for this. I don't think it helps. I think it's physiological. If it's not impacting the child's growth, I won't use these drugs. Now, completely different. Actually, if you've got a neonate where it is impacting their growth, you can try a PPI, but like I say, you try it for maybe 4 to 6 weeks. If it's not helping, you need to think of other causes. Don't just label them as reflux and leave it at that. But the important thing here is it's a stepwise approach, and the evidence base for using any of these drugs is zero. There is no evidence. So it's very clinical, it's very dependent on the child in front of you. And the important thing is don't just leave them on a PPI. If they've got better on PPIs, you can monitor their growth on PPI, but then after 6 months, maybe try about stopping the PPI, see if they can come off it. The important thing here is you don't just leave them and hope that, things just get better without you having to intervene, because actually they may need an endoscopy, they may need an impedance. So here's the next patient that I'll tell you about. It's a common patient that I see in my clinic all the time. So 3-month-old baby comes to see me for the first time with parents who've not had children before. So he's having milky vomits, and that's important. What kind of vomit is it? Obviously, we're not talking about bilious vomiting or any kind of surgical causes of vomiting, but this is just milky vomits, half an egg cupful, so not very much. But the parents are at the end of their tether. They say he's crying inconsolably, he doesn't sleep at night, he's drawing up his legs, back arching. He's taking a lot of milk, so 3 ounces every 3 to 4 hours of a normal cow's milk formula, opening his bowels fine, and gaining weight. So normally, if I was face-to-face with you guys, which I would have loved to have been, I'd have said, show some hands about what you think the most appropriate management is. So just do this in your own mind. But what would you do? You're that A&E doctor, or you're that doctor in clinic. What would you do? Would you, go through the history and offer them reassurance and then discharge them from your clinic after that one visit? Or would you think potentially this could be a cow's milk protein intolerance and want to change them to Nutramigen, Neocate? Would you refer them to someone like myself and say this patient needs an impedance study to look for gastroesophageal reflux? Would you start them on an empirical course of omeprazole to see if things get better? Or would you organise a barium swallow because you're worried about things like malrotation or a structural abnormality to account for the vomiting? So normally in medicine, I'm a firm believer that there's no black and white. And I think the point is you could do all of those things. But in my view, there is only one answer with this, and that is you would just reassure and discharge these parents. The important thing here is the baby is growing, thriving, and is only 3 months of age. This is physiological reflux. I'm not worried. I'm not worried about discharging these parents. And the reason I don't see these parents again is I don't want these parents to think I'm worried because I'm not worried. So what's the point in bringing them back to my clinic? I am very confident to be able to say, you know what, baby's fine, carry on feeding them, nothing needs doing. Okay. So next is tummy pain. So I said to you that I will talk to you about abdominal pain. So here goes. Abdominal pain, we see it all the time in pediatrics. And I think a useful way to look at abdominal pain is to think about the etiology. So generically in my head, I kind of split it up to when I'm taking a history to try and identify the etiology of the pain. So is it visceral pain, which we know is really poorly localized? It tends to be coming from the internal organs and tends to be vague. And children are not very good at telling you exactly where the pain is when they're pointing on their tummy, and it'll be all over the place. As opposed to parietal pain, which is very much somatic, really sharp, really well localized. So generically, if you have that in your mind when you're taking a history, I think it'll help you tease out the functional from the organic. So obviously, acute abdominal pain, you worry, and this is where my practice of GI medicine has changed, because when I started as a consultant, I firmly believed constipation couldn't cause acute abdominal pain, but actually I think I'm wrong, because I have seen cases of constipation where they become acutely impacted and they just have this really severe acute onset abdominal pain, and it's spasmodic and it's leads to bloating, and these children really need something doing pretty urgently. So I've put constipation in there. But obviously, is there a surgical cause? Is there a medical cause? Like, could they be diabetic ketoacidosis or a sickle crisis or renal stones? Anything, all of those things. Pneumonia can cause acute abdominal pain. But obviously what you worry about is GI causes of the abdominal pain. Is this inflammatory bowel disease, or actually on the other spectrum, could this be functional? And as we know, it's a huge sort of medical burden on medical health, because a lot of children come in with the symptom. And so it falls down to us to try and tease out the etiology of it. The important thing with the acute abdominal pain is 2 to 4% of these children carry on having abdominal pain and it becomes chronic. Affects school-age children up to, 20% of these children will carry on having this pain. 8% of our medical consultations in clinic are due to abdominal pain, and it really impacts their activities of daily living. Chronic abdominal pain, generically, definition is they're having 3 episodes in the last 3 months that's impacting their normal daily activities. And obviously, the things we worry about are with chronic abdominal pain are IBD, constipation, or functional GI disease. So as I talked to you about recurrent abdominal pain, we know it's common, particularly in school-age children. Really, I think poorly understood. We don't really understand why these children suffer with this symptom. The symptoms are often really vague. Like I say, they're poorly localized. And the important thing is you can exhaust your investigations and they don't tell you why the child is getting pain. But the child is in pain and they will come back to clinic, and the parents will give you really clear histories of how this symptom is really impacting not just the individual child, but the entire family, because they just can't live normal lives because of how severe this symptom is. So taking all that into account, when would you refer a child with chronic abdominal pain to a tertiary GI centre? And I think this is where really I can't give you an answer to this. It all depends on how far you've gone down the line of reassuring, how far you've gone down the line of giving them a holistic approach to, also touch upon psychological factors in the mind and the body. And often this is what I do at my very first consultation, because you can imagine these children do get referred to me either by the GP or by my colleagues in secondary care, because they're just at the end of their tether. They don't really know what next to do, and they're usually referring to me because they think I'm going to do an endoscopy. Now, I won't necessarily do an endoscopy. In fact, I think I rarely ever do. But on that first meeting, what I do is I'm very open from the start, and I'm very detailed about the fact that I acknowledge the pain is real, but I also talk about psychological factors playing a key part in the management. So in a way, I'm saying from the very start, I may not be able to give you a solution to this, but I'm going to support you. And I think that's important. So there are really good definitions of functional GI disorders in the Rome criteria, and it kind of teases them apart depending on the symptom. So this is functional dyspepsia, where the child is getting this persistent recurrent epigastric pain. Usually when they're eating, it's not relieved by when they go to the toilet, so very different to IBS, where often when they go to the toilet, the pain is better. Can be associated with abdominal bloating and nausea and this feeling that they can't eat very much, so they get full very quickly. And obviously you've done some basic blood tests and basic x-rays, bariums, and you haven't found any structural or metabolic abnormalities to explain the symptoms. So what could this be? Well, of course, the first thing this could be is gastroesophageal reflux disease. It could be down to peptic ulceration or Helicobacter pylori infection, or actually could also be down to some sort of viral trigger that has kind of made all of this worse. And the other thing is constipation. You know, severe constipation with fecal loading can present with sort of epigastric pain, early satiety, and bloating. So all of these differentials exist. And I think with functional dyspepsia, it's a good one to refer to a tertiary gastroenterologist, because I think with functional dyspepsia, I probably will do an endoscopy. So, you know, I'll do stool tests for a Helicobacter pylori antigen, I'll do a barium swallow, and then potentially I will do an upper GI endoscopy just to exclude peptic ulceration. Okay. The other things that will make you really prompt you to say, okay, functional dyspepsia, I need to refer, is if the child is having nighttime pain, because that's typical of GI ulceration. And if the child has already had PPI, because a lot of these children will have either been prescribed PPI by the GP or the secondary care physician, or even the parents will have given them. So if the child has had 4 weeks of PPI and still not getting better, these are the children who you should refer. Now, on the other spectrum is IBS. So, you know, we've all seen children with IBS, and here the history is where the pain is associated with something else. So either the child is getting pain, and when they go to the toilet, the pain is better, or actually with the abdominal pain, they're getting alternating constipation, diarrhea, or this feeling where even though they're going to the toilet, they need to go again. So, you know, they're incomplete stooling. Again, you've not found a structural metabolic cause for their symptoms. It's in the older age group of children. And, you know, you can talk about supportive symptoms. You know, is there family history, and, you know, are there any psychological symptoms to go with that? And, you know, the important thing with IBS here is it's all on the history, because I think, you know, if you can tease out they've got pain with these 2 of the 3 features, these are the ones I think you can hold on to and don't need to refer to us, because you can really keep talking about psychology and lifestyle features that can help this. So here's a case, 15-year-old girl, and this is typical. So a 15-year-old girl has a 6-week history of abdominal pain and the loose stools, but experiences this lower abdominal cramping and bloating with 4 to 6 stools occurring 2 days a week. The abdominal pain usually is after meals or in stressful times. There's no weight loss, no fever, no history of foreign travel, no family history of IBD or any kind of autoimmune disease. The examination for the girl is entirely normal, no red flag symptoms. Her, you know, baseline blood tests, which I think is reasonable to do, you know, when you're checking celiac, are all normal. She's on a normal diet, but she says that when she has dairy, you know, or pizza, for example, with lots of cheese, then, you know, she gets abdominal bloating. And the important thing is here, her fecal calprotectin. So you've also done that as a baseline test because you're worried about this chronic abdominal pain. And her fecal calpra is 120. Now, again, I'd normally say, you know, what do you think of a fecal calpra of 120? So depending on what you read, you'll know that a cutoff is 50 micrograms per gram. So do we think 120 is slightly high? I would say it is. You know, it is slightly high. So we've not got a totally normal calprotectin. So what would you do for this child? You're seeing her in your secondary care setting. Do you think, you know, she may have IBS, and would you get your specialist dietitian to recommend a low FODMAP diet, which we know is really effective treatment for IBS? Do you think you would refer her to a tertiary pediatric GI physician to exclude IBD, because we've talked about the fact that the calprotectin is slightly high? Or would you reassure the patient that actually IBS is nothing to worry about, it won't lead to cancer, won't lead to IBD, give her maybe some buscopan, maybe give her some peppermint oil for, you know, her symptoms of abdominal pain and cramping, and talk about lifestyle things about her diet that can help with her management of her IBS symptoms? Or would you reassure her that the most likely diagnosis is IBS and there's no treatment and discharge her? Would you alternatively acknowledge that her symptoms are impacting her lifestyle and suggest that she's been seen by a psychologist for coping strategies? So again, there's no black and white here. This is, normal life, normal child that you will see, usually a very high functioning 15-year-old who does really well at school, probably very stressed out. And I think potentially I wouldn't say any of those things are wrong, apart from maybe D. I don't think D is right, because I agree that this is a diagnosis of IBS, but I disagree that there's no specific treatment. And I don't think I would discharge her. So unlike my baby with reflux, who I'm very happy to discharge after day one of my consultation, I wouldn't discharge this child. I'd bring them back, because I'd want to see that my antispasmodic has worked, and I'd want to see my intervention has worked before I discharge, because there are things you can do to make life better for a child with IBS. So I would say the best option for this is this one here, C, because I think this is IBS, so I wouldn't yet refer her for an endoscopy. I don't think the calprotectin is high enough, and I'll talk to you about calprotectin in a minute. I wouldn't start her on a FODMAP diet yet, because FODMAP is really difficult to do, really restrictive. So I probably would just start her on peppermint oil and buscopan and see how she goes. But like I said, I would bring her back to see me, because I want to see that intervention is helping. I wouldn't yet get her in for a child psychologist, because I know the waiting times are too long anyway. And probably at the moment, I'd try and address her abdominal pain and cramping first to get her a bit better before going down just psychology. Okay, and now here's the important thing, because I get asked this a lot. What is normal calprotectin? When do you worry? And here's the thing, don't fall into the trap of using calprotectin as a marker for functional versus IBD. It's not. Now, calprotectin is released by your neutrophils in the mucosa of the gut lining. So absolutely, it's more than 97% specific for inflammatory bowel disease. But taken on its own, it's not enough. You've got to have a history behind it. So a fecal calprotectin of 120 is high, but this child has IBS. Generally speaking, a cutoff for IBD patients is 250, so it's much higher. But here's the thing, with a child who's got chronic abdominal pain and a calpro of 120, how do we know that this child isn't then going to develop IBD? And the answer is we don't know. This is why with that child, you want to keep seeing her. Potentially after giving her peppermint oil, after reducing her dairy in her diet, after giving her some buscopan for pain relief in 6 months' time, I would probably repeat her calpro, because we know calprotectins change during the day, change with time, change depending on your intercurrent infections you've had, and you'd want to see the trend. If the calpro is staying at around 100, you're not worried. If the calpro, however, has gone from 120 to 200, you are worried. And the other thing to say is there is overlap. A lot of patients with IBD can also have IBS. So here's the thing, there's no hard and fast rule, and taken on its own, it's not good enough. You've got to put it in the context of the child and what else is happening. And the important thing is that functional abdominal pain is really complex, really difficult to tease out organic from non-organic, because as I've already said, you can have IBD with IBS. So, they're not mutually exclusive. And your mind and body definitely go together, whether it's your microbiota that's in sync with your mind and body and regulating the axis. But, your mind matters. And so addressing the mind is just as important as addressing the body. And really acknowledging that actually organic factors will absolutely contribute to the child, even if they have non-organic symptoms. So a lot is on our history and examination. A lot depends on how we've excluded organic pathology, basic tests, and being really positive and confident when you say to that 15-year-old that actually this is not cancer, this is not inflammatory bowel disease, you have IBS. It's about how confident you are about saying that. And then say that, yes, your calprotectin is high, I'm going to repeat this. Don't, dismiss it as just being normal because the 250 is the cutoff for IBD. Acknowledge the fact that it is slightly high, because as well as I do, these parents will read up and then they'll Google it and see that 50 is the cutoff. And then they'll say, well, hang on a minute, the doctor said it was normal. Well, no, don't say it's normal, because it's not. It is slightly raised. And just that positive manner of acknowledging them will really help in managing this very chronic problem. I can see that the chat has things. I'll come to this at the end, mainly because I can't even see the chat group at the moment when I'm going through my slides, but I'll definitely leave time at the end to answer any questions. So investigations for chronic abdominal pain. Try, if you are going to do investigations, try and do it in one stop. I think that really helps. The reason I say this is because if you meet that child in clinic and you get all this done in one go, at least then when you're seeing the child again and again, you can then talk about psychology, you can then talk about lifestyle factors, you can then talk about friends and everything else. So try and get all of this stuff done in that one go. Do your baseline bloods, definitely test for celiac, H. pylori, urine, stool cultures, if they've got diarrhea. Now consider, depending on the presentation, could they be fecally loaded? So would you want to do an abdo x-ray? What are you thinking about, gynecological problems? Do you want to do an ultrasound just to make sure there's nothing that you're missing? I tend not to, I have to say, because, it shows me something that I don't know what to do. And, things that really aren't significant, which then causes even more problems. Bariums I will do if they're vomiting, because, you never know, you can pick up malrotation at any age. And would I do a small bowel MRI? Well, it all depends. Am I worried that this could be Crohn's disease? If I am, absolutely, I'll do a small bowel MRI. But like I say, whatever I'm worried about on the history, I try and get the medical test done in one go. I don't stagger it. So I've talked about this already, is acknowledging symptoms and reassuring them that, there's nothing serious going on. Acceptance is really key here. Get the parents to accept that actually the symptoms are real, but they're not going to cause any harm. Talk about diet and lifestyle. Consider the differential, because the differential is always there for organic pathology, and keep your mind open to the fact that this child's symptoms may progress and change. I have had children I followed up in my clinic with constipation for 2 years who then ended up getting Crohn's disease. And one of the questions is, Dr. Deb, did they always have Crohn's? No, they didn't. Absolutely, they didn't. But what I think is their constipation was a manifestation of the fact that their bowels were not healthy. Do you see what I mean? So it's having that open mind to continually reassess this child and not be closed once you've labeled them as functional to just think it's functional. And I think that's important. And absolutely avoiding excessive medications and also avoiding excessive tests. So for example, an ultrasound abdomen, I really don't use because I've never thought it's very useful. So effective treatments, my goodness, I think there is very limited evidence. We know that CBT works in functional GI disorders. I don't use famotidine really, but there are some articles that say it's potentially beneficial in dyspepsia. Fiber, absolutely no proven benefit that it helps. No proven benefit to give these children a trial of lactose-free, and I think try and not restrict their diets. Peppermint oil definitely helps in IBS. Probiotics definitely probably help in IBS. And obviously if they have abdominal migraine or those sort of symptoms, you can do sumatriptan, pizoxafen, those sort of things. But again, for a finite period where you then follow them up to see if it's helping. And the important thing here is these children don't need a referral to tertiary GI. They can be managed by their very good family doctors or a paediatrician. And here's this important article that Professor Lindsay at GOS did about consumerism and healthcare. And this really talked about the hypothesis that healthcare, consumerism in families is actually fueling children with functional abdominal pain. So we followed up these children, and actually poorer outcomes where the children continued to have abdominal pain were in the families where the parents were not really engaged with the psychological aspects. And these were families who were sort of repeatedly doctor shopping because they weren't happy with being reassured, and they really lacked insight into the psychological influences on symptoms. And so really the important thing here is the child's illness can be perpetuated by the entire family dynamic. And when you talk about healthcare consumerism, you really are needing to have that insight that this is not about the parents, this is not about their anxieties, and you've got to keep the interests of the child at heart, because so long as you are forever thinking about the child, hopefully you won't then be subjecting the child to unnecessary tests, unnecessary visits to the hospital, just because you want the parents to feel better. Yeah, so that was a really important article, I think, which still holds true even though it's 20 years ago. So now let's talk about IBD. So, this is where children, you're worried about inflammation, you would refer to us, and we know that there are 3 distinct subtypes: Crohn's, ulcerative colitis, and the bit in between, up to 20%, where we don't know one from the other, and we call them indeterminate. And that's when we've excluded infectious causes, which can also present typically like IBD. The important thing with IBD is we see 25% of IBD in pediatrics, so we have to have a high antennae of a suspicion for who these children are and refer them very early. We don't want to miss it. And we know that the phenotype in children is a lot more aggressive than in adults, where up to 60% of children will present with a fulminant colitis. So these are the children you don't want to miss, and you do want to refer them early. So what are the symptoms of IBD? Absolutely, rectal bleeding can happen in both Crohn's and ulcerative colitis, diarrhea in both of them, weight loss, growth failure, abdominal pain, anemia, mouth ulcers, arthritis, fevers, systemic symptoms. If you think of tuberculosis, all the symptoms of abdominal TB can be the symptoms of Crohn's. The important thing here is perianal disease. You don't tend to see in ulcerative colitis, but you will with Crohn's. Just a quick recap, Crohn's disease can affect any part of your GI tract, from your mouth to your anus, and skip lesions. And common places, your terminal ileum, where you have your absorption of your folate, vitamin B12, iron, which is why these things can tend to be low. It's a very deep inflammation in the transmural involvement. You can get perianal fistulae and abscesses. Histologically, you see this epithelioid granulomas, and the deep ulceration can lead to strictures and narrowing, which is why you really worry about Crohn's and the progressive nature of it. Ulcerative colitis, on the other hand, only involves the colon, usually left-sided, starting from the rectum and ascending proximally. You don't get rectal sparing. Sometimes it can affect the ileum or the gastric antrum, where you get a bit of gastritis and backwash ileitis. You don't tend to see perianal disease. It is just the mucosa of the colon that is affected. It's not deeper, not all the layers, unlike Crohn's. Abscesses are very rare. You don't get granulomas. Strictures are very rare as well. So how do we diagnose IBD? Obviously, in your clinical history and examination, you would look at blood tests for an anemia. Usually you get a microcytic anemia or a normocytic anemia with thrombocytosis, high inflammatory markers, low albumin. And the important thing here is we know that infections can either trigger IBD or can present as IBD. So you want to rule out enteric infection and celiac disease, screen for liver abnormalities, because we know that primary sclerosing cholangitis can coexist, and also a very good test, fecal calprotectin, which we talked about, will be raised in these children. We can also diagnose it through radiology, so small bowel MRI, looking for cobblestoning, skip lesions, small bowel MRI with pelvis, looking for the fistulas, barium in the children who are too young to have an MRI, so in the under 5s, you would still do a barium follow-through. CT we don't tend to use, but if you're worried about perforations or anything like that, you can do a CT. And more recently, depending on your expertise in your radiology department, a high resolution ultrasound is just as good as a small bowel MRI to look for small bowel Crohn's. Now, this is the gold standard test, is endoscopy, and what we're looking at is histologically under the microscope, sort of epithelioid granulomas here, lots of lymphocytes, really hypercellular, crypt branching, crypt atrophy, and these abscesses that you get in IBD. Macroscopically, when we look at the ulcers through a scope, so this is typical in Crohn's. I'm sorry before lunch to show you this. I would really urge you all to have a chance to go to endoscopy to look at what Crohn's and ulcerative colitis looks like by an endoscope. It really helps to really know what this child is going through, but you can see these sort of transmural sort of aphthous ulcers in Crohn's, really deep ulceration in the cecum, whereas ulcerative colitis is more granular, only affecting the mucosa, and it's a colitis pattern here. You can see here you've got these polypoid lesions where the granularity has progressed, and you get these inflammatory polyps all over the colon. Treatment, multidisciplinary, as with anything in pediatrics. You talk about the growth and nutrition, maximize their potential for reaching puberty and giving them the best long-term prognosis, so you treat them very early aggressively, because children present aggressively with IBD. The IBD drugs are very toxic, so there's a balance between risk and benefit when you're giving them immune suppressants. But if they've got perianal disease, you absolutely need to give them a biologic, because if you don't give them a biologic, they will go on to have strictures and malignancies. So you've got to sort of weigh the risk and benefit and treat early. and absolute promote psychology. You know, they've got chronic illnesses, there's no cure. So really talking about them just with their psychology and physical health and monitoring them regularly. This used to be an old-fashioned treatment pyramid of IBD, where you used to start off with enteral nutrition in Crohn's, you know, aminosalicylates like mesalazine in both Crohn's and UC, then steroids for acute exacerbations, then maybe azathioprine or methotrexate, then maybe infliximab and adalimumab, and then, if all else fails, surgery. But actually, this is all changing now. All depends on the child in front of you. If they've got perianal disease, well, actually, we'll go for biologic first. Do you see what I mean? So it all depends on the child and the phenotype of where their disease is, as how aggressively you treat them. So the important thing is here is lower GI endoscopy is a gold standard for IBD, but there are various other causes, reasons why you should refer to us. So for example, any child with unexplained anemia, diarrhea, blood loss, poor growth, you know, these are rectal bleeding. These are all patients who we would consider for lower GI endoscopy. And again, just to think about non-indications, very similar to upper GI. Constipation is not an indication for a lower GI endoscopy, and absolutely functional GI disorders are not an indication for endoscopy. So, you know, the child with IBS is not going to have a colonoscopy. Therapeutic indications, obviously, if they've got polyps, we can take them out. Any sort of hemorrhagic lesions, foreign bodies in the colon are rare. I've never done them, but obviously you could do them. And the important thing is contraindications is in the child with acute colitis, you would not scope them because there's a risk of toxic megacolon and colonic perforation. And any child who's had recent intestinal resectional surgery, you would not want to do an endoscopy on straight away. So here's my next case. I think I'm fast running out of time, you guys. So 14-year-old acute onset of dysphagia when eating a hot dog, and he's got heartburn, his mum's got asthma, father has GORD. What's the most likely diagnosis? I'm going to really rush through this, but the most likely diagnosis here is not GORD, not a conversion disorder, i.e. he's not mad. It's an acute onset of when he's eating something solid and it's impacted in him. There's a family history of atopy. This is a condition which in the past we never knew what it meant, but it's more common in boys. It is associated with food allergy. It affects all ages. And the important thing here is it doesn't resolve spontaneously. So any child presenting like this needs an immediate referral to a tertiary GI center, because this is the problem. If you leave these children, they will progress to get esophageal stricturing and potentially cancers in the esophagus. So, you know, they won't get it when they're 14, but they will get it later on. And so these are the children that we need to do an upper GI endoscopy on, because the only way to confirm the diagnosis is doing an upper GI endoscopy where this is normal, but here's abnormal, where they get these white specks, almost looks like candida in the esophagus. They get these huge linear furrows where they're bleeding, and then look at this. Their esophagus looks like a trachea, called trachealization of the esophagus. So in the past, when our histopathologist would say eosinophils are in the esophagus, we never knew what it meant. We'd ignore it. You know, when I was a trainee doing my grid training, we never knew what this meant, but actually 15 years on, we now know this is a really important diagnosis. We can't ignore it because these children need therapy. Part of the therapy I won't go into, but it's, you know, diet. We do exclusion diets. We can give budesonide as well, so, and long-term PPI. So, you know, don't ignore this condition and have a low threshold. Any child presenting with acute onset dysphagia needs an immediate referral to us. Constipation, really quickly, we know high rates in obese children, really good, nice guidelines. We know how it presents. The important thing here is do look at their anus, and if you feel skilled, which all of you should because you're pediatric trainees, do a PR examination because you want to know if the child's impacted, and it's useful for looking at the response to laxatives, but also look at their perianal region, because do they have an intercurrent group A strep infection? I've seen this quite often in children who've got constipation. You know about the investigations which we do. Abdo X-ray is not very useful, but marker study is very useful to look at colonic transit. You know about the red flags if there's fever, bloody diarrhea, delayed passage of meconium, faltering growth, anal tags. All of these things are red flags. The important thing is here, do children with constipation need a tertiary referral? No, they don't. They need a good history taken, make sure there are no red flags, and they need starting on Movicol very early on with a very early follow-up. It can be in GP practice or it can be in secondary care. But the important thing is when you start the Movicol, see these kids after a week, to make sure that they're getting better. So children with constipation don't necessarily need to be referred to us. The important thing is it's a really long-term problem, not a short-term thing where you're going to cure them straight away. Rarely needs investigation or a referral. Start off with a Movicol, but certainly add in picosulfate, senna, as you see them. And the important thing is children can sometimes need adult doses, particularly because some of these children are really quite big size, in terms of weight. This is the one not to miss. Here's very dilated loops of colon with no gas in the rectum. And this child also needs suction rectal biopsy and a referral to the pediatric surgeons. So that's the one you don't want to miss, but we all know that. And now talking about my last case, what I wanted to go through really quickly is rectal bleeding, because again, who do you refer children with rectal bleeding? So variety of causes for rectal bleeding, infectious causes, constipation, anal fissures, hemorrhoids, but actually could this be IBD? And how do you tell? So in the history, is the blood on the paper, is it mixed in with the stool? Is it chronic, is it acute? What's the quantity of the bleeding? Is there pain? Is there any other sort of family history of autoimmune illness? And really important, PR. You've got to do a PR examination to look for polyps or look for anal tone. And if you don't feel confident, then get somebody who is confident in it. And when to refer, the important thing is most of rectal bleeding in children is benign and they don't need investigations and can be followed up in a secondary care with outpatient follow-up with trial of laxatives. Obviously, if the child is systemically unwell with lots of bloody diarrhea, that's more acute. But even that, you've got to make sure it's not an infective cause before you refer them to us for an endoscopy. And this is generically, hopefully you'll have the slides that you can refer to later, but a really good way of knowing which are the children who need urgent endoscopy. And you'll see that actually not many of them do need urgent unless they're systemically unwell. So here's a real case of a 5-year-old came to A&E with a 6-week history, so really chronic history of fresh rectal bleeding and abdo pain, became worse over the last 2 days, so definitely a exacerbation in the last 2 days. Opening bowel 6 times a day, including overnight. So that's warning red flags, nighttime symptoms, and 6 times a day. Has abdo pain, has been vomiting. Examination, he's systemically unwell. He's tachycardic, he's tender in the abdomen, no palpable masses, he's got active bowel sounds, perianal is normal. What do you think the most likely diagnosis here is? A polyp is not going to give you that kind of acute onset of abdominal pain of worsening in the last 2 days, won't give you systemic symptoms. Intussusception, maybe, but again, intussusception wouldn't be the 6-week history. Infectious diarrhea, I don't think so because it's been going on for 6 weeks. So really here, the only diagnosis that you're really worried about is IBD. And the important thing here is what does he need? Does he need an urgent abdo x-ray? Yes, he does, because he's got peritonism, he's got signs of peritonitis with tachycardia and vomiting. Could he have toxic megacolon? Does he need urgent blood tests? Absolutely. You want to know what his hemoglobin is with that kind of blood loss. Does he need a transfusion? Has he got coexisting liver disease with his IBD? So you want to check all of those things. He definitely needs stool. So although I've said it's been 6 weeks and he's past the acute infective episode, the history is in the last 2 days things are worse. So could this be a trigger, an infective trigger on top of a chronic history of IBD? So before scoping him, he needs to have negative cultures for C. diff, viruses, parasites, as well as culture. Because if this child needs steroids, you want to make sure there's no acute enteric infection first. Is it useful to measure stool calprotectin? Yes, because in the acute phase, it won't be prognostic, but it's useful because it'll be in its thousands because this child has got bloody diarrhea. But the important thing is you can then follow the child up. So when he's better, does the calprotectin normalize? So that's a useful marker, but not an absolute. And the important thing here is he does not need an urgent endoscopy. You want to stabilize him. You want to get the stool cultures first. He's not going to come to any harm because you can transfuse him and keep him stable. So actually, he doesn't need an immediate referral to us. All depends on what these investigations show and how he stabilizes before we deem when he needs a lower GI endoscopy. And it won't be very soon, and as particularly you can imagine, if he's got a toxic colon, we won't be scoping him very soon at all. So that's the important thing with that. And I think I'm finally finishing here, which is really to say that GI symptoms, the ones we've talked about, really common, but actually a lot of them are fairly benign and resolve without needing much intervention. I think most of them really can be managed by a general paediatrician and do not warrant referral to us. The important thing is to have that antennae of suspicion for IBD, because unfortunately our IBD patients, particularly during COVID, have come to us very late. And there's a whole manner of reasons for that. But I think having that suspicion and referring them early would be useful. And whenever you're going to start treatments, whether it's even PPI, the important thing is to then objectively monitor that intervention, see the child again, minimum a week for constipation, 4 weeks for PPI, to make sure it's been useful. If it's not useful, take them off. And the important thing is being confident about your diagnosis and being able to reassure families, because that will lead to better longer term outcomes. And this slide really is a good sort of way to think about good referrals to us. But the bottom line is this: if you're in doubt, absolutely pick up the phone and speak to us, and we will then guide you through it. What I wouldn't want you to think is you're wrong to call us. I think any tertiary gastroenterology centre will be happy to help you and advise you. But I think the important thing is, don't just refer without having that conversation with us, because then often these referrals then get rejected, and then parents are told something, and then there's this expectation that they're going to be seen by a specialist who then rejects it, and that's not a very good outcome for the family or us as colleagues. So it's really a mutual dialogue to have, and I think any tertiary gastroenterologist will be happy to have that. All right, I think that's it. Sorry, I've way gone over my time, and I don't know if Selena has questions that I need to.
No, thank you very, very, very much for a really wonderful talk. Thank you, Dr. Derg. I was just wondering, anyone in the chat have any questions or anything they want to ask? Anything at all? I think just thank yous.